Welcome to SUNY Downstate Health Sciences University, our 11th ESRD Symposium. My name is up here, Dr. Saggi, and I have no conflicts of interest. And the theme of this entire symposium is going to be focused on sort of self-care and enhancing home therapies for patients with chronic kidney disease that land on dialysis. So why SUNY Downstate? Well, it's the venue, the population it serves, and of course, SUNY Downstate works closely with the state and the city hospital. We have representatives from the city hospital here, Dr. Mary Mallappallil, and I'm represented from the state, and Dr. Salifu, who should be here any minute, our chair of medicine. So the venue is good, and it caters to a large population of patients with lots of chronic diseases, diabetes, hypertension, and of course, chronic kidney disease. First of all, I want to thank iPro Network Region 2 for the desire to help out our patients and the vision like ours, which is to help our patients, and patients come first. And I thank all the vendors for supporting this event. I thank all our presenters and attendees. And I also thank our CME department and other staff members who have been very supportive to make this happen. As it is, it's always a tour de force with bare minimal resources and funding, but we made it, we are here. Again, thanks to our leaderships at SUNY Downstate. Historically, Dr. Delano, who might or might not come here, I'm not sure, but she started the first home dialysis program, actually almost in the country, and she had 85 patients at one point on home hemodialysis in the late 60s, early 70s. And of course, Dr. Friedman, on whose shoulders we all stand, received the first federal grant in the entire country to create and start outpatient dialysis, and the first unit was Kings County Hospital. And he also started one of the first fellowship programs in nephrology to train our physicians. Dr. Bailey was mentioning there is a suitcase kidney that he invented, and he was highly impressed by that. So, and of course, our Dr. Salifu, who supports all of us in so many endeavors, and I'm very thankful to him. And he should be here any minute. Normally, he begins this, and he says, "Brooklyn, let's wake up." So, but he's not here today. And this is me, my journey for making one patient start first home hemodialysis. And it really was a big effort. Like I tell myself, it takes a village, a community to finally bring someone home. You see Dr. Friedman, Dr. Delano there supporting me, and my first home dialysis nurse. With that said, I'm very delighted to invite my first speaker, Dr. James Bailey. Dr. Bailey serves as Robert S. Pierce Endowed Chair in Internal Medicine, Professor of Medicine and Preventative Medicine, and Director of Center for Health System Improvement. He's come all the way from Tennessee to share with us his thoughts on how chronic diseases can be managed and also how self-care can be encouraged. Dr. Bailey continues to practice general internal medicine as a primary care physician for adults and complex chronic diseases, and teaches doctors in training. He's a principal investigator for the PCORI, which is called Patient-Centered Outcomes Research Institute, funded study management of diabetes in everyday life. It's called the model, which recently demonstrated the effectiveness of low-cost, motivational text messaging and health coaching to improve healthy eating and other essential diabetes self-care decisions in low-income people with uncontrolled diabetes. This is a specific population which we all have to deal with. He was the PI, or principal investigator, for the Center for Medicare and Medicaid Services, CMS, funded Safe Med study that demonstrated how hospitals can drastically reduce hospital readmissions and overall costs through better outpatient care. Dr. Bailey has served as the PI for over 10 major grants and health systems improvement research initiatives and has over 75 journal articles. book chapters, and publications. And a side note, I'm grateful to him. He gave me his book. I was requesting it, which he recently wrote. And if everybody can get a handle of it or ask him how to get, you should read it. I'm going to start reading it tomorrow or today. His research appears in many peer-reviewed medical journals, including JAMA, Journal of Internal Medicine, and Annals of Internal Medicine. His novel, The End of Healing, which is a book he has brought here, A Journey Through the Underworld of American Medicine, received a Benjamin Franklin Book Award for popular fiction. Dr. Bailey's work focuses on patient-centered approaches to improve quality of care and health outcomes for people living in medically underserved areas with multiple chronic diseases. He enjoys leading multidisciplinary teams to address systemic changes using innovative approaches to meet the triple aim and simultaneously improve patient experience, maximize population health, and reduce healthcare cost. With that said, we both were chatting not long ago, and I said, my vision is a world without kidney disease. That's my vision. So with that, Jim, welcome. Let's give him a big hand.
Good morning, everyone. I'm deeply honored to be here and humbled to be amongst such a wonderful group of caregivers and healers in this difficult battle against chronic kidney disease. And I'm already so impressed with your work and understand the commitment, dedication, persistence it takes to care for people with CKD and end-stage renal disease. Let's see, there we go. I have no significant disclosures to make today, and I'll just go over my objectives really quickly. Today we're going to summarize key evidence on the effectiveness of motivational interviewing-based health coaching for promoting weight loss, hypertension, and diabetes control, and even diabetes remission. I presume most of you have heard of motivational interviewing. We don't think of it as a technology so often, but you probably know it is the best proven health counseling technique for empowering patients to make potent changes in their own health behaviors. So we'll be talking about that today. I'll also detail the benefits, the really proven evidence-based benefits of place-based neighborhood-level care as opposed to hospital care. I'll describe how health coaches and other community health workers can help lead CKD prevention efforts. And I'm truly dazzled by Dr. Saggi's vision of a world without CKD. And I truly believe we can create it. We can build that world, but it will take flipping the healthcare system upside down. And we'll talk about how we can do that. Not an easy task, right? Not an easy task. I will delve some especially into the management of diabetes in everyday life study and the implications of its results and the early results from our neighborhood health hub program in Memphis, an innovative program working to get care into the community. And lastly, I'll identify some of those most promising emerging approaches for reducing spending on unnecessary high-cost sickness care, which, you know, we're all about the sickness care business, right? But reducing that spending on low quality of life care, honestly, in many circumstances, by extending preventive and primary care into the community. Okay, you know the challenge. You really see it every day. I know everyone here sees this challenge every day. And one of the members of our Patient Advisory Council in Memphis brought it home to me in an especially potent way a few years ago. This was a pastor that was part of our congregational health network, and he said of his community, the community of Whitehaven in Memphis, which is a suburb right outside in the outskirts of Memphis, he said, now there are more dialysis centers than primary care clinics in my neighborhood. And I thought, surely that's an exaggeration. And our team looked at it, and we realized, oh my God, it's true. In Whitehaven, this community of about 100,000 people, neighborhood of Memphis, here are the dialysis centers. There are, I think, 6 major dialysis centers and fewer primary care clinics in this community of 800,000. Unbelievable. It's a low-income area. Primary care is encouraged to locate there, right? But isn't that symbolic of the brokenness of our healthcare system? More dialysis centers in primary care. It was also brought home to me in our community. I don't know if it's like this here, but it's exceedingly hard to get diabetes education. And if you've even heard of it, diabetes prevention program services. You know, we know diabetes prevention program, it's evidence-based, it helps reduce progression to diabetes. It's paid for at a very low rate by Medicare, yet hardly anywhere provides it. There are 4 states that don't have any sites for diabetes prevention program services, and it's certainly true in Memphis. Very few places you can get these proven preventive services or even diabetes education outside of hospital settings. And yet we know these are the most important services, right? These are the services that have a chance to turn the tide on CKD. So this is definitely part of the problem. Now, where did this problem come from? Well, I didn't want to make a bad joke and say it came from New York, but because it didn't. It's much bigger than that. But how many of y'all have heard of Abraham Flexner and the Flexner Report? You know, transformed medical education, and said Flexner became fascinated with the great Sir William Osler, doctor at Johns Hopkins, and his idea that the laboratory and the places of healing needed to be brought together. And as a result, they advocated and supported the medical schools around the U.S. at the time that were really focused on laboratory medicine, using emerging science to really transform care through the laboratory. And Flexner was very influential through his report and the commission he brought together that ended up effectively closing almost all of the medical schools that admitted women or blacks, and really focusing on putting resources into the high-tech healthcare centers. And you've seen these places. One of the ones they really invested in, the Rockefeller Institute, right up the river. You know, in a tremendous place of science, right? And this led to the science-focused, laboratory science-focused hospital, these great temples of healing, like the ones we have in Memphis, right? The ones you have here. Huge buildings with extensive technological facilities, imaging, laboratory, and people in America love these places, right? They've got all kinds of amazing technologies that entrance us, really, and we look to these places for healing. But I think you know this is part of the problem, right? These are centers for sickness care, not primary and preventive care. People come there after things have gone horribly wrong, and look for us to pull them back from the brink of death at huge, tremendous cost. But they are very emblematic of the problem we face, right? So I got intrigued a few years ago by something that Robert Wood Johnson brought forward, an idea that we needed to flip the clinic and really transform primary care by having doctors partner with patients. Healthcare teams work as teams instead of all about the great healing doctor in the hospital temple, really to create a situation with an informed, activated patient who could help to lead their own care in partnership with their doctor. But I realized even then that we have to go much farther. We don't need to just flip the clinic. We have to flip the system, right, to extend care into the community. And why do we need to do that? Let's sort of dig into those details a little bit. First, we know from numerous studies that healthcare works better when it's close to home, when it's in your borough, when it's easy to access, and when it's a trusted, comfortable place that you can, and convenient to you in your everyday life. Numerous studies show that neighborhood availability of primary care, and I would extend primary care to say those things like diabetes prevention program services, diabetes self-management education, strongly predicts what they call realized access, which means primary care utilization, how much of the essential services you get. And you saw from that earlier slide that even though we have a fair amount of primary care in our neighborhoods, it's not getting us to goal, right? Particularly for low-income people. And I used in my first slide the example of African Americans in the U.S. Less than 50% of people get to goal for hypertension. Less than 50% of people in these high-risk communities get to goal for diabetes or are at goal at any, or controlled for hypertension or controlled for diabetes. And even for wealthier populations, more privileged people like ourselves, control rates aren't a whole lot better in the U.S. I mean, can you imagine in any other industry that we would accept 50% failure rates? It's not acceptable. So that is our challenge, to get to 80, 90%, or even better control rates. And to do that, we have to get out into the communities that we serve. So I'm going to introduce our neighborhood health hub model, which is truly, in many ways, an old model of care, an old-fashioned model of care in new clothes. It's derived very much from the international health literature and the substantial literature indicating when you have health care in your neighborhood that's friendly, accessible, and focuses on the essentials, you're more likely to get the care you need most. And I'll come back to this, but in our neighborhood health hub model, we focus on really the basics: screening, coaching, and connecting to care. A lot of people, even with multiple chronic conditions, we found in our community, even with multiple chronic conditions, don't have regular primary care. They use the ER in the hospital as their major source of care. So we start with screening for the most essential factors: hypertension, diabetes, and obesity, right? They're really one disease, not really three in many ways. So we do screening for those three critical medical conditions, and just those three. And then we screen for social needs and mental health needs. And we've got more and more evidence that social determinants of health, or social drivers of health, really do drive health, right? And this isn't a new idea either. In Memphis, we have great love for the heritage of Martin Luther King. And I hope if you come to visit us in Memphis, you'll come to see our National Civil Rights Museum at the site of his assassination. Wonderful place. But as part of his Poor People's campaign, he was championing in the early 60s are addressing social determinants of health. And now we know that these factors do truly drive cardiovascular, cardiometabolic health. And not only that, there's evidence now that initiatives that work on these factors can actually help improve cardiometabolic health. And for the first time, doctors in nephrology and multidisciplinary teams are beginning to work, and I suspect you do here, to identify those social needs and do what you can to close the loop. Well, that's one of the things we try and do in our health hubs, is that closing the loop on social needs. And we're realizing that it's an important part of primary care. You're probably familiar with these factors that affect health outcomes, but it's worth repeating that clinical care is really very important and accounts, how well we do in the clinic, based on numerous studies, accounts for about 20% of human health, of our health status. And that includes the services we offer in our ICUs and our dialysis centers, right? Those services really are life-saving. 30% of our health status is determined by our health behaviors. And, the second I talked about in our health hubs, screening, coaching, and connecting to care. The coaching piece, both individual and group, doing like diabetes prevention program services, individual and group health coaching really focuses on health behaviors. And a health coach, we have a training and certification program that's run by our university, is a type of community health workers. Traditionally, community health workers work more on the social needs. Health coaches work more on the health behaviors. And then that 40% down at the bottom is social factors and environmental factors, right? That truly are the biggest drivers. And we have to get involved in those issues if we want to realize Dr. Saggi's dream. And I want to point out, and I think you know this, but you've probably heard the term actual causes of death. These are the underlying causes of death that contribute to cancer, heart disease, stroke, etc. And for years in the U.S., tobacco has been number one of the killers, of the actual causes of death, with obesogenic behaviors, poor diet and physical activity, a close second. And this is data from 2000, where you can see poor diet and physical activity not being quite as big a factor as tobacco. But here, and this is a little hard to see, but in the first, let's see if, well, I don't think my pointer's going to work, but in those first two columns, you can see that tobacco now accounts for only about 16% of death, whereas sedentary lifestyle and low-quality food accounts for nearly 20%. So obesity is now number one, obesity-associated behaviors, in terms of the number one killer of U.S. adults. And this is where we certainly have to focus our attention. You know about this pandemic of obesity and its terrible cost. To see this in our lifetime, I think I still find it hard to believe, as we've moved from 2 or 3 people in 100 with obesity, maybe 1 in 100 with diabetes, to now nearly 1 in 2 with obesity, not just overweight, and 1 in 6 with diabetes. It's a health transformation like anything we've ever seen in the history of humanity, really. And you have to ask what's driving it. What's driving it? And I want to ask you that question. What's the vector of this horrible, horrible pandemic of obesity, diabetes, hypertension, CKD? I think it's processed food and the marketing, of processed food. It also, you're in one of the most walkable cities in the country with public transportation. That matters, right? It really helps. But I think personally the biggest vector is processed, non-nutritive, addictive junk food. And we'll come back to that. So this is a heat map of obesity. And you can see I'm from the South. So this is especially disturbing to me. But nowhere in our country are the rates of these diseases very good, right? This is the map for diabetes. This is the map for heart disease. And this is the map for CKD. And CKD is truly a pandemic as well, isn't it? And all these maps look basically the same, don't they? I was a little surprised myself just to remember that over 20% of older adults have CKD. That's really pretty terrifying. And we have to do something about it. So I do believe that addictive, high glycemic, processed food is the vector. And the companies marketing these products are marketing death to our people. They're marketing poison. And we shouldn't accept this. We need to think about our agricultural policy, our health policy, so that it promotes foods that are actually healthful for Americans. And doing that is not an easy task, but we have to talk about it. We have to talk about it, how to reduce exposure of our children to these addictive, unhealthful foods. And you probably know this, one of the worst of all is the chip, right? And actually, I think I have a slide about this. Let's see if it works.
Lay's potato chips. Bet you can't eat just one.
Nobody can do that. A potato you can slice this thin makes a chip so light, so crisp, you can eat 1,000,000 of them, but nobody can eat just one.
Delicious.
It's really true, isn't it? No one can eat just one. These foods truly are addictive, and they cause glycemic spikes. Our blood sugar goes down as we overshoot with our insulin, and they drive tremendous hunger. And one of the studies that brought this home to me best of all was this recent study, about 10 years ago now, from Cell Metabolism, where it gave people 2 weeks of a nutrient-identical junk food diet and then switched them to 2 weeks of a deliciously prepared but nutrient-identical, plant-forward, healthy diet, and saw what happened to weight, food satisfaction, etc. And, people could start in either group, so it was a randomized crossover study. And what they saw was extraordinary. In just 2 weeks of eating a processed food diet, people on average gained 2 pounds. In just 2 weeks of eating a really well-prepared, plant-forward, non-starchy vegetable, natural diet, people lost on average 2 pounds. 2 weeks, unbelievable. Unbelievable what the power of that diet. Now, it was, they called it an ad libitum diet. So, because even though the portions that were initially served were calorie identical, people could go back for seconds. And what do you expect? The people with the processed food diet didn't feel satisfied, and they went back again and again and ended up getting a lot more calories, right? That's how processed food works and how it drives weight. But interestingly, the investigators found that food satisfaction was identical. No differences in food satisfaction. So there's this long fallacy. You know, people think of dieting as taking willpower, and that willpower was the crucial ingredient to losing weight, because the healthy food's not really tasty after all. You know, it's a sacrifice to eat healthy food. Well, that's a fallacy, right? Well-prepared Mediterranean food, there's nothing better, nor anything healthier. So it's a false choice between unhealthy, tasty food and healthy, untasty food. We need to offer people delicious food that is truly satisfying. And there's science behind how we can do that, right? Of course, it starts in your kitchen. Now I'm going to review a few of the studies that have shown how primary and preventive care support for weight loss can even reverse diabetes. And I know many of you have heard and seen some of the results from the diabetes remission studies, and I'm going to briefly review those. Two of my favorites are the DIRECT study, which was in England and Scotland, and the Look Ahead study, both of which showed that diabetes remission for people with early diabetes is indeed possible, using a relatively high protein, 30% calories from protein diet that tends to suppress appetite a little bit, and very plant forward. Now, I'm going to start with DIRECT, and they actually use a liquid diet to start. But the fundamental part of their overall intervention involved nurses doing health coaching in primary care settings, and after the intensive weight loss period, they transitioned people to a plant-forward Mediterranean diet. So I've included this study here. They actually put people on an extremely low-calorie diet. You can see 830 kilocalories on average. So this is an intensive weight loss approach. And the reason they did this is we've learned now that rapid weight loss is easier than slow weight loss. The only downside of that is, of course, you have to have physician supervision, and even they stopped, you can see, all diabetes medicine, all antihypertensive medicine on initiation of the intensive weight loss, because people will drop their blood pressure very rapidly within the first week of intensive weight loss. They will get hypoglycemic. The one other downside to rapid weight loss is, of course, gallstones, right? It can increase your risk of gallstones, but it's a lot easier to lose weight fast. And the one other downside to fast weight loss is weight regain, but we'll come back to that. We'll talk about that a little bit. So that's what they did. Liquid diet, very low calorie, and what they showed is that they were, for people who stayed in the program, they were able to achieve an over 30-pound weight loss on average. Over 30-pound weight loss on average, and the weight loss was fast, within about 3 to 6 months, and they've maintained it well for a year. And not only that, now they've got about 4 years of follow-up, and they've maintained it with the support of those health coaches for now through that 4-year period. And here were the two main outcomes were achievement of over 15 kilograms, over 30 pounds of weight loss, and remission of diabetes, defined as getting that A1C, that average blood sugar level, below 5.7 and maintaining it. And their results were really astounding. A quarter intention to treat, that means including all the people that dropped out, a quarter of the people lost over 30 pounds. And nearly 50% of people had remission of their diabetes. Now, these were all people with less than 6 years of diabetes diagnosis. We know that the longer you have the diabetes, the less likely you can achieve full remission. But even in those folks, you can achieve increased insulin sensitivity and improved glucose control. So these results show us that remission of diabetes, early diabetes, that's a point where we can really catch people and work with them to help them turn back this horrible risk factor. You can see that the likelihood of remission was directly related to how much weight they lost. For people who lost more than 15 kilograms, 86% of them had full diabetes remission. Really incredible. So we need to be able to help people lose weight and lose weight safely and effectively, because it is absolutely part of the answer to a world without CKD. Now, what kind of diet? What kind of diet should we be recommending? You've already heard me say the Mediterranean diet. And I lived in Italy, our family lived in Italy for 1 year, and it was an eye-opening experience for how delicious healthy food can be. And of course, you're lucky in Bronx to have so many Mediterranean restaurants. And I'll recommend one last night, RAS. Have any of you been there? Ethiopian vegetarian restaurant, extraordinarily good and healthy as well. But the science has shown that that Mediterranean diet is the best diet for losing weight and keeping it off. And in this graph, you can see the low-fat diet is red. This is the best comparative effectiveness study we have for diet, published in the New England Journal of Medicine a few years ago. The low-fat diet led to less weight gain and less maintenance of weight loss. Low-carbohydrate diet, like that keto diet or Atkins diet, you get really rapid weight loss going into ketosis, right, in the very high-protein diet. But the problem is that you get a lot of weight regain as you come out of ketosis. And so no significant improvements in weight loss with the low-protein diet, lots of weight gain. And we know weight fluctuation is unhealthy, right? Going up and down, yo-yo is not good. From a practical point of view, with the high-protein ketogenic diet, people can't stick with it. That's the problem. Good for weight loss, but people can't stick with it. So when they return to eating more normal calories and they continue to liberalize the unhealthy fats, right? The solid fats like butter, animal fat, etc., eating those fatty steaks. So we lean people away from that ketogenic diet and toward the plant-forward Mediterranean diet with half the plate at every meal. Green leafy vegetables, broccoli, Brussels sprouts, cabbage, kale, collard greens, right? Telling people that should be half their plate at every meal, a quarter of their plate non-starchy vegetables, a quarter of their plate lean protein, and doing that at every meal. Well, that's not the usual American diet, but we can help people get there. So what about our guidelines? Do they point us in this direction at all? I know many of you are probably familiar with the U.S. Preventive Services Task Force guidelines for preventive care. You know, they grade preventive services A, B, or C. There are hardly any preventive services that are graded A. Two of the only ones I can remember are colon cancer screening and hypertension screening and treatment. Those are, incredibly high levels of evidence in support of those preventive measures. Mammography is a grade B. It's a grade B, which means they're very good. There's very good evidence of benefit. but maybe not quite as good as colon cancer screening. Similarly, about 10 years ago, the U.S. Preventive Services Task Force put out a guideline for obesity, and they said that every single patient we see with obesity ought to be referred for intensive multi-component behavioral intervention. Every patient with obesity, grade level B, strong evidence, ought to be referred for intensive multi-component behavioral intervention. And they said one of the essential components was motivational interviewing style health coaching to help support people with weight loss. Now, do you have that in Brooklyn? Raise your hand if you know a place you can send people for intensive multi-component behavioral intervention. Please, am I seeing any hands here? Doesn't exist in Brooklyn. You know, it was the situation in Memphis. There were a few places. You could go to the bariatric surgeons and they would give you a little nutrition class, right? If you were signed up for surgery, right? But otherwise in Memphis or in high-income areas, you know, there's Weight Watchers, and it kind of qualifies. Weight Watchers kind of qualifies. But as far as part of the traditional health system, we couldn't find any place in our town where we could refer half of our patients. In our clinic, it's half who have obesity. How are we going to, and we had no place to refer for one of the most essential preventive services, right? So this bothered us, as it should bother you, right? That we need a place to refer half of our patients for really intensive counseling because we know it works, And how does it work best? Well, 50 years of evidence say that this approach, motivational interviewing, raise your hand if you've heard of that term, motivational interviewing. Good, I'm seeing a lot of hands. You know, it's an empowerment-based counseling approach that takes practice. We've been trying to get this as part of our standard medical student curriculum for every medical student. We have a world-class online interactive program for people to learn to do this, but it takes practice. It's not the way we're used to talking to patients in general. It starts with their agenda, not ours. It focuses on clarifying what their goals are and then helping them think and encouraging them talking about how they can make a change. And, you know, most people want to make the change. They want to have a healthier life for themselves and their families. And what the literature has shown is that lots of diverse interventionalists can successfully learn and practice this approach, that health coaches from the community served, people with a high school education or better who have a gift for communication, that they can do as well as psychologists using this technique. And the literature is clear that motivational interviewing is more effective than education, like I'm doing now, unfortunately. It's more effective than education for weight loss. Isn't that interesting? Large meta-analysis, and here are the main trials they looked at a few years ago. All of the point estimates were in favor of motivational interviewing. Instead of saying, you need to do this, 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 and this, and here's what you should eat, and da-da-da-da-da, we have to move into a listening mode, reflecting, summarizing, and advising people and helping them navigate the social drivers in their own life on their path to better health. So I want to call out the Patient-Centered Outcomes Research Institute. And as many of you know right now, this is not a good time for research in the United States. You know, we are under attack in our academic health centers, and we have to stand up with courage and speak out on behalf of science, right? Not just with our patients, with our community, but with our own government to help to restore the meritocracy and the focus on science rather than opinion in terms of our path to health. But the Patient-Centered Outcomes Research Institute is part of that, it's really focused on applied research in the community, and it's been one of our funders, so I want to acknowledge them. They've funded a lot of studies in this area on how we can help people change behaviors. And one of the studies they funded is our own Management of Diabetes in Everyday Life program. And when we started this program, through PCORI encouragement, we started by asking our community, what are the interventions you want? What are the interventions you think in our community of Whitehaven and South Memphis do you think would make the biggest difference? And one of the things that we heard loud and clear from our community was we're interested in diabetes education. We know diabetes is a big deal, and we're interested in health coaches. We're interested in people who look like us in our community who can help us on the path to better health. And we've continued in our work to engage our patients and our community leaders as expert advisors. You know, it's often the people in our communities who can best tell us how to make better care work. And here's what we found. We randomized people, as you can see in that part of the slide to the left. We randomized almost 700 people to getting health coaching with educational materials, very visually appealing, patient-vetted and selected education materials. So first arm was health coaching and education materials. Second arm was text messaging, the red arm, motivational text messages from the doctor's office, little reminders about taking, you know, their amlodipine every day, if that was their blood pressure medicine, reminders about healthy eating and physical activity, or educational materials alone. Well, the first thing we found out was that in most of our participating clinics, we had 19 clinics in medically underserved areas that we worked with, is that in most of those clinics, people weren't routinely getting educational materials. And if they were getting educational materials about diabetes, they weren't particularly colorful, visually appealing, or understandable for patients. And what we found in our study, as you can see in that first graph, is that even the educational materials intervention, that even educational materials alone improved healthy eating and exercise behavior. And for the health coaching group and the text messaging group, we saw about a day improvement per week in healthy eating and physical activity. In other words, people in those health coaching and text messaging groups had about a day on average extra healthy eating as a result of that intervention. So we, like many others, showed that all these interventions work, right? And that really our conclusion was that every patient with uncontrolled diabetes ought to be getting health coaching, ought to be getting text messages, ought to be getting high-quality educational materials. And furthermore, in our qualitative work, we found that people really liked getting this stuff, that they felt more engaged in their care, they felt more connected to their primary care, I would venture to say to their nephrologist. And actually, we found that patients in health coaching went to see primary care more. The health coaching didn't take the place of primary care, it encouraged it. And we saw major improvements in diabetes control too. particularly in the health coaching arm, interestingly. Now, you saw at the beginning, as we were thinking about the challenge of our upside-down healthcare system, those temples to healing, those beautiful, sparkling new hospitals popping up around the country, specifically targeted, and where do they build those new hospitals? What sort of communities do they put them in? Wealthy communities, right? They put those fancy hospitals as close to the center of where all the well-insured people are, you know, where the rates are highest. Well, in Memphis, probably like you here in Brooklyn, we're trying to target those most needy communities, not the wealthiest communities. And in Memphis, here are the census tracts that we've really been focused on in North and South Memphis, that census tracts where the adult prevalence of hypertension is 53% or higher. We have census tracts where 75% of adults have hypertension, and where well over 40, 50% of adults in those census tracts have uncontrolled hypertension. And this is just showing some of our data. You know, we do have to start with data looking where are the neighborhoods of greatest need, right? Where can we make the biggest difference? And let me return to our neighborhood health hub model. We already talked about those aspects of partnering with an informed and activated patient, inviting people into health coaching, doing screening for essential medical, social, and mental health needs, and getting the advice and guidance by the neighborhood we're working to serve. And then you can see the bidirectional referrals with primary care and specialty care, as well as community-based services. We thought when we started we would be doing mostly referring to primary care and specialty care. But what we found is instead, because of the lack of the services like diabetes prevention program services in our community, we get a lot more referrals from primary care than we refer to them. Isn't that interesting? That the doctors want their patients to have these life-saving services. So why neighborhood health hubs? Because we want to engage and empower patients as co-creators in their journey to better health. These are our 3 initial locations. We're now up to, we will soon have 5 locations in Memphis in our most medically needy neighborhoods. And we have 2 rural locations that we're piloting as well. People feel safe coming into our health hubs. The health coaches are approachable. They're from the communities served and can meet people where they are. And it's all built on relationship and trust, right? This is what one of our health hub facilities looks like. We have as loss leader activities, exercise activities, cooking classes, in the sense that those aren't reimbursable by insurance. But we're trying very hard to sustain our effort, you know, because it's all about money after all, through reimbursement from Medicaid, Medicare, and commercial insurance, and trying at the same time to serve all people to the best of our ability. We've talked about screening, coaching, and connecting to care. On the coaching side, making those diabetes self-management education and DPP services easily accessible. Smoking cessation as well. And we can bill for these services. We've also gotten dispensation from our Medicaid Bureau. We've gotten guidance from the Medicaid managed care organizations to pay for health coaching delivered services in this arena in the context of team-based care. So our Medicaid program is starting to buy in. Now, we talked about screening with a scale for obesity, you know, BMI, blood pressure, and diabetes through random blood glucose is our leading screening indicators. We use those mostly because they're easy, they're quick, and they're important, right? But should we be doing point of care a kidney disease screening? Well, I knew I needed to touch on that today, and this is from one of the best studies on community-based CKD screening, and you can see some of the approaches they tried. And as you can see, if you select your population, in many of our health hubs, this would, more than 50% of our clients would select in, but you see really high rates of positivity for CKD. We know that's true, right? And so you certainly could add in CKD screening, right? Using some of these proven approaches like protein creatinine, urine protein creatinine ratio. And similarly, these are some of the studies. This is a meta-analysis looking at community-based CKD screening, not screening everybody, but those at risk, right? And you can see really high rates of positivity. So it's certainly a worthy thought. And I'm very intrigued by point of care testing for CKD. The other thing I find is that we have to really teach our doctors not to say CKD, right? We have to teach our doctors to use common language and say, you know, because so many patients will say, you know, who've had CKD for years will tell us, I've never heard I had kidney damage, you know? And so we say, do you know you have damage to your kidneys? And we've seen you've got early damage. We need to do all we can to prevent further damage to your kidneys so you don't need to go to dialysis. We have to really work on using that common language. I was interested to see the CKD treatment and risk modification guidelines from the Kidney Disease Improving Global Outcomes guidelines. And, you know, they put lifestyle change right up at the beginning. But when they talk about treatment and risk modification, they don't yet have referral for intensive multi-component weight loss interventions on their diagram. It's beautiful other than that. I love it that they have food, exercise right at the top. But these are real interventions that we need to think about deploying even more. Just while we're on since we talked about diabetes remission, we're trying to popularize food as medicine through our health hubs. And we have a program called Heal Diabetes. HEAL is an acronym, Healthy Eating and Active Living to Reverse Diabetes. And at least let people know with early diabetes that food offers an opportunity for reversal, and that early diabetes can be reversed in many circumstances. And that's a treatment option that you ought to be able to choose from, right? So our early data, we've had about 14,000 visits. We're getting started with this model. We've only served about 2,500 patients at this time, but the people we serve come back. They come back again and again. We have an average of 6 visits for the people we serve and engage in health coaching. And we've already got results showing that engagement in health coaching, not just from past trials, but from our real-world experience, that our average weight loss thus far is over 4 pounds. In patients with obesity, we've had people who've lost 50 and more. And we get about an average 15 millimeter reduction in blood pressure. That's huge, right? And that's with food, right? And referral back to primary care. We're not adjusting their blood pressure medicines, and yet we're seeing big improvements in blood pressure, blood sugar. And we know that can translate into decreased ER use and costs, and we're working on demonstrating that. People from a qualitative perspective, people come back to the health hubs for psychological support, tangible benefits like food, we distribute food, and empowerment. And people really tell us about how they've changed the way they live. And I'm getting close to the end here, just one patient story. And this is Miss Penny Ward, who's given us permission to use her name. She said, I can say my blood pressure is lower than it's ever been in my entire life. When I last checked it, it was 123/78. My A1C is below 5.5. And when I first started, my A1C was 10%. This is my first time being under 200 pounds in 43 years. So, as we think about creating a world without CKD, this is within our means. It really is within our means and our ability if we follow the science. And I think it starts with figuring out a way to refer every patient with obesity, hypertension, or diabetes for health coaching. And that means paper-based referral approaches. This is one of our paper-based referral forms, at least the top half of it, but also building electronic record connections, right, where you can do electronic referrals to these resources in the community, and they can actually send their health coaching notes back to you. We're trying to do that. We're doing it now with our safety net providers in Memphis. So referring every patient with obesity for multi-component intensive behavioral weight loss interventions. Support community screening. You guys can be the champions for community-based screening for obesity, diabetes, and hypertension, and maybe even CKD, right? Knowing that even when you're screening for obesity, you're screening to prevent CKD. So partnering with your community-based organizations to really hold up everybody being screened. And then finally, don't be afraid to use food as medicine. I trust you have a culinary medicine program here of some sort, but we really need to adopt food as medicine and have those colorful handouts to show people the way to better health through better food. We can really support community initiatives to increase access to healthy food. And of course, New York has been a leader in this, right? So really proud of the work you're doing here. Thank you so much. Appreciate your time.
Thank you, everybody, and thank you, Jim. This was absolutely phenomenal, an eye-opener, which we can emulate in Brooklyn, maybe other boroughs in New York. So first, I'd like to, of course, thank Jim from my heart that he really showed us the way. And second, I want to invite Dr. Moro Salifu, our chair of medicine, Dr. Salifu, and he has been the champion in helping so many members of this community, and I thought we can partner together with you, Jim, to start similar processes in Brooklyn. We also have members who can help us business-wise develop such models. So anyway, Dr. Salifu.
Okay. Good morning to all of you, and welcome to the 11th Annual Symposium, Emerging Trends in Dialysis Care. That was a phenomenal keynote speech I've heard in a very, very long time addressing this topic. So thank you very much. We're going to open the question and answer session soon, and then we'll be asking questions. But I just wanted to welcome all of you to the conference. This is the 11th year we're doing it, and Dr. Saggi has been leading this effort to bring real information to our community and providers at large, and to make sure that everyone in Brooklyn and beyond are up to date with what is happening nationally and to improve the care that we provide to our patients. So I really want to thank Dr. Saggi for all the effort that you've been putting into this symposium. And from the College of Medicine, I spoke to the dean. The dean also is very appreciative and also welcomes all of you as well. So I'm chair of medicine. I also run the Brooklyn Health Disparity Center. It's NIH funded for the last 20 years. And we've been doing similar work, addressing social determinants of health in the community and the like. So hearing you speak about these things, yes, was a home run for me because I have also been involved in that area for a very long time. We have it set up with a lot of people in the community. And again, it's NIH supported for the last, I would say, 15 years with, millions of dollars on an annual basis that we get from NIH to support the work that we do. So what you've said today really, really hits home. So I'm going to start the Q&A session, and I will start with a question to you. The community hubs that you talked about, these are really, really very important for patients to come in and get the coaching and all that stuff. My take from your talk is that this is funded from the PCORI. Now, when the PCORI funding is over, what happens to the health hubs?
Yes. Yeah, the PCORI funding is over.
Oh, it's over.
And we're actually funding our health hubs through a blended model. A lot of the initial funding indeed was grant funded. United Healthcare has been one of our funders, actually, and we've been very thankful for their support. Our biggest funders, two funders right now, are the Shelby County, our county government. So they have been our county commissioners, so impressed by the program that we're hoping to become more of a line item rather than a commission to commission, mayor to mayor effort for our health hubs. So county funding, philanthropic funding, and increasingly we're trying to bill insurance. So we project that within the next 3 years that 50%-ish of our funding will be covered by insurance, both fee-for-service billing, which the rates are low, sadly, right? The rates are really low. But also we're trying to get some employer-based and insurance value-based contracts. If we engage your patients and they achieve goals, if they achieve outcomes, then you pay us, right? Because we want to be paid for outcomes, right? So ultimately, this kind of work needs to be sustainable.
Okay. My second question to you, and we'll come to the audience, is the food industry is about $2 trillion. That is the market cap for the food industry. So obviously there are interest groups, and they are just sitting right on the steps of the U.S. Congress, lobbying to make things happen. And they are spending billions and billions of dollars to make sure that their interest in pumping these processed stuff into the foods is protected. So until that barrier is broken, they will continue to enjoy their $2 trillion industry. How do we break that? Because if we don't break that, then we will keep talking about it. As an example, you came into Brooklyn today. We have a population of about 2.7, 2.8 million people. There's not a single farm. How do you get breakfast? How do you get lunch? How do you eat dinner? Where is it coming from? How do you feed 2.8 million people every morning, give them breakfast, feed them lunch, feed them dinner, and there's not a single farm. There's not a single place where you can plug something and eat it naturally. How do you do that? And then there's another person sitting on the U.S. Capitol protecting the $2 trillion. How do we break these barriers so that we can come into a more socially structured sort of health system that prioritizes health instead of sick care? How do we do that?
Oh, what a wonderful question. Lobbying takes, for us, without those billions of dollars behind us, takes courage. And every one of us can lobby, right? And we know what to lobby for, and we can do it with true heart and conviction. I think it's really critical, particularly now, to lobby and get to know our Republican congressmen, legislators, and help them understand these issues. It's hard to do that sometimes, right? If you disagree with some of their policy agendas. My favorite agency, really right now, because they've funded us in the past and do such good work, is the Agency for Healthcare Research and Quality. Yes. It's being slashed, gutted. But the new secretary, Kennedy, has some of the right answers. He certainly doesn't have them all, right? But we need to lobby him aggressively on this food as medicine issue, and really press, that we move to reduce and even stop the agricultural subsidies for the for soy, corn, and wheat. Soy, corn, and wheat, which really don't offer much nutritional value, and increase subsidies for fresh vegetables, locally grown, right? We can do that, and we can bring that back. So those are the kinds of things I think we need to work aggressively for, and do it without fear.
Okay. All right, questions? Okay. Errol Carter. Speak clearly.
Yes,
loudly.
good morning. I'm Earl Carter, the administrator for dialysis here at Downstate. And my question goes back to some of the approaches that we're taking, in healthcare, in research with the current administration. And I want to start out by saying, like this morning, listening to NPR, they were talking about the new Pope, and they use a term to describe him. A coin with two sides. They were talking about his good and the bad. And I'm thinking that with the healthcare industry, and especially when it comes to research, maybe we need to be looking at the administration as a coin with two sides. And you talked about the different approaches to diabetes care. We need to look at the approaches, how we approach the administration. And my question is anybody looking at that? Because right now, we have an administration that's actually doing some of the things that you mentioned might be difficult to do. Changing how these big institutions do research. He's taking that on. Nobody else was brave enough to do that in the past. The food industry, the president and the health secretary are now getting ready to take on the food industry. So the question is there a group out there that's looking at the approach that we've been taking all along and is focusing their approach that matches up with them that could be beneficial overall?
Like you, I'm thinking about this. We want to see where we can find those areas of partnership. And and also speaking clearly in the areas where we have different ideas, like vaccination, right? Where the science is clear in the benefits of vaccination and the lack of association with things like autism. But on food policy, we could have an opportunity here. It's kind of hard to believe that we might, but I think we should do everything to take advantage and try and find common purpose around taking on the food industry. I think you're exactly right. I think it's very easy to other groups and people and point out the bad. It's often harder to find common ground. But I think this is a time where we want to really work to find the common ground around the science And perhaps there's an opportunity to stand up with in the regards of increasing access to healthful food and limiting the power of the food industry to promote commodified, non-nutritive foods.
Thank
Great,
you.
okay.
And Jim, I have a question.
Okay, please go ahead.
Thank you. I see somehow the pharmaceutical industry is really, also addressing it, not with the food pathway and behavioral and creating hubs, but now flooding the market with GLP-1 agonists and all. And, you can see Oprah Winfrey lost so much, and she's a model. Do you want to comment on that? I mean, I think they need to partner with us too then.
I could not agree more. These new medications, the GLP-1 agents and the SGLT2 inhibitors, are miraculous new drugs. They're really wonderful drugs. But we're also learning that unless people also take on healthy eating, they can't achieve and maintain and sustain weight loss, even with these wonderful drugs. So I think there is a lot of room for partnership with the pharmaceutical industry, increasing access for minority and other low-income populations to these medications, but in turn, making sure that that access is coupled with, and perhaps with industry support for readily availability of motivational interviewing-based health coaching in the context of multi-component behavioral intervention programs, DPP programs, diabetes self-management education. We can commonly champion that with the pharmaceutical industry.
Okay. Dr. Steinbeck, you have a question? We can take one more question here. All right. We can take one more question before the break here.
Is our co-sponsor of this program. She's in charge of the Kings County Hospital. Mary.
So I really like the point that you made about motivational interviewing. We have a kitchen that we have for patients across the street. We have a gym there. Our mayor, Eric Adams, actually came there and did a teaching cooking class. I've written a book with a fellow and cardiologist and some medical students here called New York Nutrition, What's in Our Ethnic Foods. And that's about 99 recipes of what we have here, including low sodium soy sauce, etc. The key thing is, with all of this, your key piece that you said, motivational interviewing, really gives back the ownership of their health to the patients. And I think, all of the light bulbs went off in my head saying, okay, maybe this will work. Because we go for the easiest things, the GLP-1 agonist. It's another thing that we are giving very paternally to patients. The moment you stop that, the weight comes back. So I think that's really where we need to go with all of the resources that we have, giving it back to the patients.
Control, yeah.
Thank you, Mary.
I love that. I really love that. You said that just so well. Is patients want better health for themselves and their families. Why not give them the agency to make their own changes and chart their own path to better health? So well said.
I would ask one last question. We close and then we'll go for it. He's going to be available so you can reach out to him and ask questions. I know Dr. Saggi was able to find you to come and give us this talk, but how do people actually find you and your programs?
I think Dr. Saggi is going to have to answer that question.
Now, in your neighborhoods, I know you have the program, but how do people actually find out and actually come to you? Is it advertisement? Is it local TV? Is it
Yes,
people going to the communities? How do they actually find you?
Doctors and people in the healthcare industry, we don't think enough about marketing and communication, but we've gotten to be very good friends with the marketing and communication people. and actually have gotten some pro bono support from the United Healthcare Marketing and Communications team. You know, they've gotten a lot of bad press recently, and some of it well-deserved, but they're also doing some good work in leading in this area. So yes, we use radio, we use free TV whenever we can get it, we use the newspapers, but our biggest source of engaging clients has been through referrals from primary care and specialty care. We're trying to get referrals from dentists now as well, for every family with premature tooth decay. So referrals, you know, that warm handoff when your doctor, your trusted doctor says, oh, you really should consider this, that's very powerful. Second, lots of word of mouth. And so for word of mouth to work, people have to like the service, right? It's got to be a good and friendly service. And then lastly, we do tons of community outreach events. So our coaches, we're trying to staff our hubs where we can do, you know, particularly in the spring, summer, and fall, we do pretty much every weekend or at least once a week. We have some sort of community outreach event in partnership with our churches, with our synagogues, with our mosques, and other community-based organizations, schools, a lot with the schools.
All right. So with that, please join me in thanking Dr. Bailey for a wonderful keynote speech and Q&A session.